So kind of the next topic we wanted to go to, you had some questions arise on traumatic arrest, and I think kind of the point with, so if you respond to a patient and you know they have had a major traumatic event and they're in cardiac arrest when you arrive, you know, there's kind of been talk where you need to put them on a monitor, that kind of thing, but when you get back to that patient that you're taking care of post-trauma and they go into cardiac arrest, you know, that's kind of a different approach. So kind of I guess your teaching points on trauma arrest and how we should manage that.
Well, I think for trauma arrest patients, you have to keep in mind, is it blunt trauma or penetrating trauma? The chances of survival from a blunt trauma arrest is low, extremely low. So those people you're probably just not going to resuscitate. There are many places that if it's a blunt trauma arrest, they're really not doing very much at all. You know, if it's blunt trauma, you've evaluated for an airway obstruction, you've opened their airway, and they're not in VFib or VTAC. Even on a blunt trauma, if they're not in VFib or VTAC, they've got an open airway, you've opened the airway, you know, if you've intubated them, great, but if you've opened the airway and you can tell that they have no airway obstruction and they're in cardiac arrest on the scene, then you can really say, you know, that these people are dead on the scene. So many systems are following those sort of three guidelines: appropriate mechanism, no airway obstruction, and no persistent VFib or VTAC. Then they're not working these blunt trauma patients. Now, okay, when you move into the penetrating trauma, that's a little bit different, and even our protocols address that. In that penetrating trauma, you know, deserve rapid transport to the emergency department, to a trauma center, because many times these people will have a chance of survival, especially if you can get somewhere where they can do an open thoracotomy and make sure they don't have a ventricular injury, stab wound or gunshot wound into the ventricle that someone can repair in the emergency department quickly and then get them up to the OR. So I think that from a penetrating standpoint, then you do need rapid transport. Decompress that chest with a needle, needle decompression. Get them to the emergency department. CPR in progress. Treat their shock. You know, if they're hypotensive, you know, keep in mind that these people may have cardiac tamponade. There are lots of injuries that can be reversible with penetrating trauma. Now, again, with that being said, if they are in asystole when you get on the scene, even from a penetrating trauma, then, and they don't have an airway problem, you've opened their airway and they don't have an airway obstruction, then I think you can probably make a case not to work that patient on the scene either. And some people even say that if they develop asystole in transit to the hospital, that you can stop resuscitative efforts. Now, we all know that once we've started that transport, we're going to continue that transport. So I think in recapping, blunt trauma, no airway obstruction, no VFib or VTAC, appropriate mechanism, then probably not going to do very much for that patient as far as working that cardiac arrest. Penetrating trauma, a little bit different. They do have an increased chance of survival as compared to a blunt trauma. Rapid transport, treat their shock, CPR, decompress the chest, and obviously keep in mind that as I recap a little bit, if they're in asystole and they don't have an airway obstruction, you can probably make a case not to even work that on the scene either. Now, of course, we all know that have been there, sometimes just from a scene standpoint, sometimes you have to work those cardiac arrests to get them off the scene. It's a hostile environment, etc. We know that, and so I think there are extenuating circumstances. Pediatric trauma codes, even blunt trauma, many times you're going to work those patients to get them off the scene from a logistical standpoint, and that's that's perfectly fine. That there are extenuating circumstances to all of that. So I think that's a pretty good way of addressing it from our standpoint. We know that they're probably not going to get that blood trauma back.
And at the point you begin to work a cardiac arrest, then ACLS algorithms apply, and beyond the kind of the old adage of treat the apparent cause. If they're in defib, we're defibrillating. You're following the ACLS algorithm, so nothing really changes
No.
from a trauma perspective.
No, other than, I do think you need to make sure that their chest is decompressed.
Right.
I think that really need to keep in mind that hypovolemic shock or may be the cause of this cardiac arrest along with a primary injury, and treat their shock very aggressively. Now again, that permissive hypotension that we've talked about in the past.
Yeah.
If you get those people back, then you need to make sure that you're trying to maintain that blood pressure, 90 or a radial pulse that's palpable. But just keep in mind that, that these people may very well need aggressive shock therapy.
Okay.